It's okay. I think that many people are only coming for the class today. That's okay, anyways. So, guys, today, as the topic says, we are going to discuss the guidelines. Okay, the guidelines of American Diabetic Association, which is widely used and accepted, worldwide to understand the treatment pattern, diagnosis, and everything about the diabetes. So yesterday we just recapped a few things. I had the few questions for all of you as well. But today I'll be taking you through the complete guidelines. Okay, complete guidelines, except the treatment, but still will touch upon the treatment because the treatment is the main crisp of this series. Right, we'll be talking the classes of the drugs and drugs one by one, but let's talk about the guidelines, what the guidelines says, what the newer guidelines says, the 2023 guidelines says, and how they look at the diabetes worldwide, right? So I'm just sharing the guidelines with you here. Okay, yes. So these are the guidelines. Okay, guys, I'll just, yeah. This is how it starts, the guidelines, right? Standard of care, diabetes care, right? I think I have showed you yesterday also. So now, but before that, I would like to understand from you, okay, one thing, one very important thing. How many of you have read the guidelines before as well? How many of you know how to read the guidelines, guys? Please tell me. Yes, this is very important because reading the guidelines is a quite task for everyone. Yes, people. Please tell me, how many of you have read the guidelines by yourself? Yes, any anything, any guidelines. No, I'm not talking about the standard of diabetes care, the ADA guidelines. There are multiple, there are many in cardiology, in orthopedics, in psychiatry, in pediatrics, in heart failure. There are many type of guidelines. Okay, many types of guidelines, right? So I'm just asking, like, have you read the guidelines before, and how do you read? what's the what is your method to read the guidelines, or it just simply take the like open the book or open the guidelines in the computer and just start reading it? Do you understand what exactly and how exactly the guidelines are being written? That's important because everyone follows those guidelines, right? Everyone. So how the guidelines are being written? Any comments, any questions? Come on, guys, don't tell this. Yes. No answers I'm getting. And even people start leaving the class. Yes, guys, please tell me something. Okay, so let me tell you how the guidelines are being prepared first. Okay, this is very important. You must understand, you must know, all of you. Okay, because you are from the nursing background, you are from the pharmacy background, pharm Ds. So if you don't know about the guidelines, then what else and who else will be understanding the guidelines, right? This is the main important thing for any kind of disease, any kind of condition, right? So you must understand how to read guidelines and how these guidelines are being created or being formed, right? Or being written, right? So see, in the starting, like when there are no guidelines, right? If you want to create the guidelines for something, new condition, right? Suppose there is a new condition, or suppose we don't have guidelines for hypertension in India, Indian guidelines, right? We have the guidelines for many things, but for hypertension, we don't have our own guidelines, right? We are following ESC guidelines, we are following, JNC guidelines, we are following IHT guidelines, International Hypertension Society, IHS guidelines. We are, many other guidelines. So how do we create the guidelines? See, guidelines are not just being created, by asking the people or by asking the views of the people or by something else. They are being created or being, formed purely on the basis of research. Okay, purely on the basis of research, and the research not only in 1 to 10 or 100 or 1,000 peoples, but in the millions of the people, millions of the people. right? They take the bigger studies like clinical trials. Okay, you must understand, you must know that what is the hierarchy in the research. So the top level research articles are meta-analysis and systematic reviews, then those are randomized controlled trials, then non-randomized controlled trials, then it comes to, I'm going the ascending order. So first number one rank in the evidence is meta-analysis and systematic reviews, right? And then it goes to randomized control trials, then it goes to non-randomized control trials, then it goes to the studies means cohort studies, case control studies, and then it goes to case series and case reports, right? One by one cases. So that's how it goes, right? But guidelines are purely made on the top class research, randomized controlled trials, all type of controlled trials which are multi-centric, multi-state, multinational, right? So some organizations, like suppose we are talking about the diabetic guidelines today, AD, American Diabetic Association. So suppose they want to come up with the guidelines. What they will do, they will search the entire research, whatever has done, entire literature, right? Entire databases, whatever diabetes related research has been done, whatever, wherever, right? They will create they'll create the outline, what exactly you have to write. Like suppose before coming to the writing part, they will create a task force. Okay, they create a task. These guidelines are being written by the task force. Task force is nothing but a team. Okay, team of scientists, team of top doctors, team of associate peoples, team of the writers, medical writers, team of the statisticians, and the team of the people who are entering the data, who are analyzing the data, who are collecting the data. There are many people in the team, so the entire team of preparing the guidelines is called as task force, right? And that task force is presided by one person, that is called as president or director of the task force. He take care of the entire thing, he take care of the entire setup plan and how it goes, timelines and everything, right? And then it starts with the outlining, right? First, like suppose I'm talking about standards of the care in diabetes. So like how they will start, first they will tell about themselves, like how did they do it. Okay, what were the evidence levels. Okay, I'll come to that part, evidence levels. Okay, and then they will come to the diabetes, right? What exactly the diabetes is, definition of the diabetes according to different societies, different centers, different doctors, different organizations, multiple things. Okay, and then they will come to how to what are the sign and symptoms of the diabetes, what are the types of diabetes, what are the, whatever the disease is, they will cover everything. Okay, everything means everything about that, individualization of the therapy, insulins, algorithm of the treatment, algorithm of the pediatric treatment, algorithm of the GDM treatment, algorithm of the type 1 treatment, algorithm of the type 2 treatment. There are multiple things. If you look at the cardiology guidelines, because cardiology has, if I talk about just myocardial infarction, MI, right, heart attack. So there are 5 guidelines only for MI from one organization. I'm just talking about one organization. There are multiple organizations, top organizations like American College of Cardiology, American Heart Association, and NYHA, and there is European Society of Cardiology, multiple. But only one society, only one organization has 4 to 5 guidelines only for MI, because in MI also there are multiple types. And STEMI, stable angina, unstable angina, right? So like complete ACS guidelines, there are multiple things to understand, right? Similarly, but we don't have the guidelines differently for different diabetes, because diabetes is not as vast as cardiovascular diseases. As a disease it is complex, but not as the cardiovascular diseases are, right? So they have compiled entire thing in one paper. One paper means one book, or we can say the one guidelines, one, they have compiled it all together. You can see there are 306 pages in this guidelines, 306 pages. So what happens is, in the chronology, if you understand, first they review the literature after outlining the things, and then the reviewers, or we can say the quality check people, the doctors or the associate professors from the world class colleges, they come up all together and sit and check the quality of the content, if the research has been done properly or not. If you have attended my scientific writing classes, I always teach about internal and external validity check for the papers, for the guidelines, for anything, whatever the literature is available right now, right? So they check the internal and external validities, and they try to understand what exactly they have to include into the guidelines, into the format, into the outlines. And once the entire outlining is done, entire reviewing process is done, I mean the literature search and the review of that literature is done, they select the papers, like, okay, these papers will go to the sign and symptoms, these papers will go to the definitions, these papers will go to the treatment part, these papers are only, this research is only on insulin, this research is only on OHs, this research is on SGLT2 inhibitors, this research is on complications, this research is, I mean, they do everything properly, and then it goes to the scientific writers. Based on that, they compile the manuscript, right? Then based on that, they compile the manuscript, and that once the manuscript is ready, then again it goes to the reviewers, it goes to the president, it goes to the committee, and the committee approves it. Committee send the corrections, multiple time corrections, and then at the end, ultimately your guidelines come, and it takes years. Okay, not only one day or 6 months or 8 months, it takes years. Okay, first time to come up with the guidelines, it takes years. Okay, maybe 1 year, 2 year, but it takes a lot of time. And now, as I was telling you guys that ADA, American Diabetes Association, they come up with their guidelines every year, first of the year, first day of the year, 1st January of the year, they launch their guidelines. So they come up with the updations, they come up with the new recommendations, they come up with the new drugs, they come up with the changes in drug profiles and side effect profiles based on the evidences, like whatever data has been published in last 1 year, in last 12 months. Usually they, I mean the ADA, if I talk about, they start in September to September, right? They complete the data, they complete the guidelines by September, and then the review process only goes, and they come up with the guidelines in January, right? So September to September, they collect all the data on diabetes, whatever is published, and based on that, they make the changes, they make the modifications in the treatment patterns, and they add the drugs, remove the drugs, they make the first line therapies, they change the first line therapies, second line therapies. So it goes on. Okay, it goes on every year, they change the guidelines, right? And then that's how the guidelines are being prepared for you, and then you guys read the best content, and then everyone follows that for the clinical validation. Okay, clinical validation means previously it was internal and external validation like the content is correct or not, statistics is correct or not, but now it is if the guidelines are clinically correct or not, right? So they treat the patients based on the guidelines, right? They use the medications based on the guidelines. They measure the risk and benefit ratios while treating the patients based on the guidelines. So that's how they check the internal, external, and now the clinical validity of the guidelines, right? So that is just the format how they usually come up. I mean, it's just crisp what I told you, right? But now let's come to the main point. American Diabetes Association standard of care in 2023 guidelines. So see here, if you look at this, see, this is about journal, and this is all about editorial board, and this is about board. Okay, this is about board, right? Like about the diabetes board. And now this is the content. Okay, now this is the content, what we say the outline. Okay, what we say the outline. See, before reading the guidelines, you have to understand how it has been written, right? So introduction, methodology, summary of the revisions, like what exactly they have changed from last guidelines to this guidelines. Okay, what they have changed exactly, that is important to understand, right? So I think, yeah, we went down. Yeah, here's the content. Yeah, right. So and then see, the first chapter here is improving care and promoting health in population. population based, how they can do, like tailoring the treatment. And then it comes to the classification and diagnosis of diabetes. Then prevent or delay of diabetes occurrence, right? Onset of diabetes, how we can prevent or delay it, and how we can delay or prevent the associated comorbidities also. Comprehensive medical evaluation and assessment of comorbidities, how to treat the comorbidities, that is different thing, but how to assess, how to evaluate, how to diagnose the comorbidities, that is one thing. So here there is assessment of comorbidities. And see the updation, if you look at this, diabetes and COVID-19, this is another, new comorbidities have been joined here. In last past 2 years, diabetes and COVID induced diabetes, you know COVID is one of the major risk factor now. And the long COVID also, the people who had COVID, they are more prone to get diabetes, right? So they have added the specific chapter of diabetes and COVID-19. Okay. Then facilitating positive health behaviors, well-being. And then now it comes to the, glycemic targets, diabetes technology, like what are the blood glucose monitoring, what kind of devices are there, how to use those devices like glucometers and all, and what are the continuous glucose monitoring devices, what is insulin delivery, and what are the insulin therapies, injections, how they work, right? So guidelines means they are compiling everything, they are giving one stop solution to, you people, students, clinicians, and the people, doctors, whoever is involved in the diabetes treatment, right? And then obesity management. Here, see, look at this, obesity and weight management to prevent the diabetes, right? And now if you look at this, now it comes pharmacological approach for the glycemic treatment, like type 1 diabetes, type 2 diabetes. Then cardiovascular disease and risk management, because cardiovascular diseases are major risk factor and comorbidities. Macrovascular complications, right? Cardiovascular disease. Then chronic kidney disease and risk management. Retinopathy, neuropathy, foot care, all complications and their treatments they have given here. Then how the diabetes behaves in, elderly patients, right? So geriatric diabetes and geriatric diabetes treatment, right? And special cares in that, end of life care, children, adolescents, I was talking about the different types. So type 1 diabetes in children, type 2 diabetes in children. And then pediatric to adult care, how it transit, okay, how it transformed. And then management of diabetes in pregnancy. If you look at this, if you read guidelines, guys, you don't read guidelines, you just read the 10 years old book or 15-year-old books, whatever they have written before. And then you follow those drugs and guidelines to, treat the patient. And when you look at the prescriptions in the hospitals as an intern or as a nurse or whatever, whatever is your profession right now, you are into healthcare, when you look at the, prescription, and you say, oh, this is not what I have read in the in the book, because books are outdated, right? You have to read the guidelines, updated papers, and then only you can match up with the things whatever is going on in your hospitals, in your wards, in your rounds, in the patient treatments, right? And then diabetes and advocacy, and done, right? So let's start here. So it is the introduction and methodology, right? So what exactly here you have to read in this? See, you have to read the level of evidence. Can someone tell me here what is the level of evidence, guys? Can someone tell me what is the level of evidence when we read the guidelines or whatever, according to you, what do you feel the level of evidence is? How they choose the drug for first line therapy? Tell me, how they choose the drug for first line therapy, or how it is being replaced? Yes. See, it's not like that is like committee decided to keep metformin as a first, line therapy, or committee has decided SGLT2 inhibitors now, for all the, cardiac complications and diabetes patients. How they do that? Can someone tell me from the students? Yes, guys, it is very important for you, for all of you to understand and learn. How do you do that? How they do that? Can someone tell me? Okay, so let me tell you. This is very important to understand. See, there are the level of evidences. Okay, as I told, internal, external, and clinical validation. So all the studies, whatever the studies comes to the market, published in the journals, Nature, NEMJ, NEJM, or BMJ, or MDPI, or wherever, Oxford, or anywhere they are publishing the journals, Taylor Francis and all, wherever. right? So how do they do that? They read the paper, they read the research, and then based on that, they decide the evidence level. If it is top evidence, right? If it is the top evidence, not only if it is the systematic review or randomized control trial, but if it is, matching the clinical, but if it is matching the clinical internal and external validity also. Okay, right. So they look at the multiple things, and then based on that they decide the level of evidence. Like this paper comes to C level of the evidence, B level of the evidence, or A level of the evidence, or D level of the evidence. They have the levels till E also, right? So based on the grades of the levels, they include those and give them the preferences to make the guidelines, right? So you look at these guidelines, see, look at the ADA, whether it is ADA or any other agencies preparing the guidelines for diabetes, cardiology, orthopedics, they usually use certain, these parameters only. ADA, evidence grading system for standard care of diabetes. So see, look at the E. E is expert consensus or clinical experience. Like people are sharing their experiences. Suppose the top doctor in the country, he's telling SGLT2 inhibitors are the best. Okay, this is called as expert consensus or clinical experience. And this is kept at the end, at the lowest level of evidence. You know why? Because this is just the experience. This is not scientifically validated. Understand, this is not scientifically validated, but this is just a comment. This is just a statement based on the experience. You cannot just take it as, take it through the guidelines, right? But yes, if there is nothing, you can definitely, consider it as a level E guidelines or level E level. Okay, then see, supportive evidence from poorly controlled or uncontrolled studies, like suppose cohort studies, maybe not cohort studies, suppose like cross control studies, case control studies, or case control studies, or some other low level studies. Okay, if these type of papers are being published where inclusion exclusion criteria is not strict, where statistics was not strict, where objectives were not clearly defined, where sample size was not clearly defined. Like the statistically, the internal and external validation was poor, right? In such studies, they just keep them as a C level of evidence, right? C level of evidence. C level of evidence means like, okay, there is the scientific, they have done something scientifically, but it is not purely validated, perfectly validated, or there is no what we say, that fizz of the restrictions. Okay, restrictions means the inclusion criteria, exclusion criteria, objectives, multiple things are there. Aim, what was the hypothesis, what was the sample size, what was the methodology, right? So that poor kind of studies comes into the C level of evidence. Then B level of evidence is like well conducted prospective cohort studies, registries, and some kind of meta-analysis of cohort studies. Okay, so this type of studies comes into the B level of evidences. And if you come to the level A, clearly evidence from the well conducted, generalized, randomized controlled trials. Randomized controlled trials. Evidences from a well conducted multi-center trial. Evidence from a meta-analysis that incorporated quality ratings in the analysis. Supported from a well-conducted trials or at one or more institutions, like multinational, multi-centric, single-centric, or maybe multi-institutional clinical trials are also being included in the A level of evidences. So whatever is available, based on that, they give the priorities to those studies, and then they prepare the guidelines. So this is the main what we say, the process of reading the guidelines. First you understand the evidences, and then later I'll tell you, when they are discussing about the drugs, they will tell which one they kept in level 1, 2, 3, and which drug is based on the B level studies, C level studies, or D level studies. Okay, so you will understand that time. Now see, ADA statements on multiple things are there, right? So this is the chapter 1, and here, okay, it ends here, and then I think we have started the chapter. Okay, this is the chapter 1 exactly. So that was just evidences, right? Improving care and promoting the health in populations. Okay, so you can read it. They are talking about the population health and care delivery systems and all, right? I'll not go to that. And see, you will see whatever and however they have written, they have given all the references at the end of chapter. If you look at the end of the chapter, there are all the references which they have considered to write this chapter. Okay, and you can see the reference numbers here. Okay, so there are all the references. See, in one chapter they have used nothing but 123 references. In one chapter they have included 123 references. As I told, they first do the literature survey and then review it, and then based on that they write the outlines. Right, now the second thing, classification and diagnosis of the diabetes, and we were just discussing about that yesterday. Okay, now this is the important thing to understand and learn here. So diabetes can be classified into general categories like type 1 diabetes, that is due to autoimmune beta cell destruction, and that is also called as insulin dependent. Okay, insulin dependent, and see, usually leading to the absolute insulin deficiency. As I told, because of the beta cell destructions, this is absolute insulin deficiency. Okay, in adulthood, that is also known as LADA, latent autoimmune diabetes of adulthood. Okay, and I told you MODI is being considered the what we say the modified or the early onset version of type 2 diabetes. So here we can see type 2 diabetes. It is a non-autoimmune progressive loss of adequate beta cells, frequently on the background of insulin resistance. Actually, insulin resistance. Okay, and the metabolic syndromes like obesity and other metabolic syndromes. Okay, then the third thing is there is not only one, multiple, like monogenic diabetes syndromes. Okay, monogenic diabetes syndrome, neonatal diabetes, maturity onset diabetes for young. Okay, the MODI, what we were talking about yesterday. And then cystic fibrosis or chronic pancreatitis. You must know, I told you yesterday also, chronic pancreatitis is one of the type of diabetes as well. And then drug induced diabetes, chemical induced or drug induced diabetes. See, look at this, drug induced or chemical induced diabetes, right? So that is also one type of diabetes. Here look at this, drug induced diabetes is one type of diabetes, and majority of the drugs are glucocorticoids, which causes the diabetes. And then it is gestational diabetes, that is diabetes diagnosed in the second or third trimester of the pregnancy, that was not clearly over diabetes prior to gestation, means that is the new onset of diabetes only during the pregnancy. Okay, and then they have clarified like what are the diabetes 1 and diabetes 2, you can understand. And now diagnostic tests for the diabetes. Okay, diagnostic tests for the diabetes for the multiple things. Look at this. Here there are the characteristics first of all, right? Characteristics for stage 1, stage 2 and stage 3 diabetes. And look at this criteria to diagnose the diabetes. Here they have given criteria to diagnose diabetes. We were discussing yesterday also. First is FBG, fasting blood glucose. So fasting blood glucose, as I told you, according to guidelines, that should be less than 126 mg per dl or 7 m mole per liter. Okay, 7 m mole per liter. And fasting is defined as no calories intake for at least 8 hours. So it is usually taken in the morning when person has not taken anything or not administered anything for past 8 hours, right? And then it is 2 hours PG. PG is postprandial glucose. Okay, postprandial glucose. So postprandial glucose is like it should be less than 200. Some other guidelines says 180 also, but it is less than 200 mg per dl or 11.1 m mole per liter. In India, we use mg per dl only, right? So maybe some hospitals use m mole per liter also. It is just depending on the kit, which kit you are using to check it. Okay, usually in India we check in mg per dl, right? So this is the 2 hours ppg. Okay, ppg or ppbs we call it, postprandial glucose or postprandial blood sugar, whatever we say, right? There is only one thing, 2 hours ppg, that is taken, the blood samples are being taken after 2 hours of the food, right? And then A1C, HbA1c, hemoglobin, glycated hemoglobin, right? HbA1c, that must be less than 6.5. Okay, that must be 6.5 or 6.5 percentage or 48 mmol per mole. That's also a kind of percentage only. Now I have a very important question for all of you guys. What is the stage for pre-diabetes? What is the level we consider for the pre-diabetes? Can someone tell me what is the pre-diabetes condition and what is the level of HbA1c in pre-diabetes? What's the level of ppbs or fbs in the pre-diabetes? Guys, tell me the pre-diabetes. Let's talk about the pre-diabetes. Yes, everyone. I want answers, guys. Yes, what is pre-diabetic condition? Yes, everyone. What is pre-diabetes? Are you guys able to hear me? Yes, what is pre-diabetes? I don't understand that no one knows. Come on, guys. This is not true. The pre-diabetes, diabetes is very common. Yes, tell me, people. Okay, okay, yes. Okay, so pre-diabetes is not the years before the diabetes, or pre-diabetes is also, not something which can occur, or you can understand that was 3 years before the diabetes or something. But pre-diabetes means before onset of diabetes, people can understand that their HbA1c or glucose levels or the sugar levels, plasma sugar levels are at the higher side. They are at the risk to become diabetic. Okay, pre-diabetes means there are certain levels where people are at the higher side of having these levels. Okay, and they are considered to be pre-diabetic, like they are at the very high risk of being the diabetic anytime. Okay, like for pre-diabetes, if I talk about HbA1c, if it is 6.5, less than 6.5 for the normal, so usually pre-diabetic is somewhere 6.0 to 6.4. Okay, or that is 6.5, 6.4 to less than 6.5 is pre-diabetes. Okay, if I talk about FBS, right? If I talk about FBS, similarly, 100 like 101 to 126 is pre-diabetes. Okay, so absolutely normal is less than 100. Absolutely normal is less than 6 for HbA1c and for FBS. And PPBS also less than 180. Less than 180 is absolute normal. 180 to 200 is pre-diabetic. Okay, so you are at the higher side. You are at the higher side of sugar levels, but considered as normal. But you are, more prone to have diabetes as you know your levels are increasing or touching the 6.5 or 200 or 126, right? So pre-diabetes is the condition before the onset of diabetes that is called as alarming state also. Okay, pre-diabetes is an alarming state, like, okay, if you are now not considering your health first, then you will be diabetic soon, right? So in the pre-diabetic state, people can control it. People can easily control it. Okay, how they can control it? They can stress, I mean, they can reduce the stress. They can modify their lifestyle modifications by morning walks, running, wake up early, and dietary modifications, and multiple things are there: exercise, jogging, everything. They can stop smoking, stop drinking alcohol, right? So there are multiple lifestyle modifications. Based on that, the person can prevent themselves from going into the diabetic state. becoming from becoming the diabetes, they can stop themselves, right? So that is the alarming state. Pre-diabetes is the alarming state. Okay, guys, so you have to understand that, very important thing, right? So now the similar thing, they also have shown somewhere. Okay, yes, screening of the diabetes and pre-diabetes. So pre-diabetes here is, okay, so somewhere they made one fantastic, yes. So see, one more very important thing I want to tell you guys before we go to that. Here is the pre-diabetes. See, FPG 100. See, look at this. If you read these guidelines, it is ultimate. Ultimate. You will understand everything. Okay, you will become the master of diabetes. See, FPG. What I've selected wrong. Okay, so FPG 100 mg per dl to 125 is pre-diabetes, right? 2 hours PG 140. It is 140, not 180. 140, my bad. 140 to 199, like less than 200, is for 2 hours PG. For HbA1c, it is 5.7 to 6.4. Usually, it is 6 to 6.4 also previously, or in some other guidelines that is 6.0 to 6.4 also. So here, in according to ADA guidelines, that is 5.7 to 6.4%. That is considered as pre-diabetic, right? And how you can understand if you are at the risk of diabetes or not? They have given the scoring system. Okay, they have given the scoring system. Let's understand it. You can check yourself, you can check your relatives, you can check your people, like if they are at the risk of diabetes or not. How old are you? It will give you the point here. Okay, it will give you the point here. If it is less than 40 years, 0 point. If it is 40 to 49 years, then it is 1 point. If it is 50 to 59 years, then it is 2 point. If it is more than 60, it is 3 point. That means your age also is the risk factor, as I told you yesterday, for the diabetes, right? And then, are you a man or women? So if you are a woman, 0 points. You are at the lesser risk of getting diabetes than men. If you are a man, then 1 point additional. Okay. If you are a woman, then have you ever been diagnosed with gestational diabetes during the pregnancy? If it is yes, then you are at the risk. So you will get 1 additional point. Do you have a mother, father, sister, or brother? The family history is very important because onset of diabetes in type 2, in case of type 2, as I told you yesterday, is 10 years early onset. Okay, and if you have a family history, you are 70 to 80% prone to get diabetes. Okay, whether those are parents or grandparents, it doesn't matter. Okay, so it is very, very important, right? So do you have a mother, father, sister, or brother with diabetes? If it is yes, then 1 point. Have you ever been diagnosed with high blood pressure? Hypertension is one of the major risks. If it is yes, then you are at the higher risk. Are you physically active? Physically active means what? Like your sedentary lifestyle. If you have the sedentary lifestyle, yes. If you are not having the sedentary lifestyle, then no. Okay, so here, look at this. They have the height and weight category also based on the obesity. So whatever matches yours, you can just, it is in the lbs, okay, pounds, but you can convert it into the kgs and check out, right, in which point, which category you are. If you are in this category, 1 point. If you are in this category, 2 point. If you are in the category 3, obesity, actually that is based on the bmi, so it's 3 point. Add up your scores, add up your scores, and if your score is 5 or higher, then you are at the increased risk of having diabetes. You understand? You are at the increased risk of having type 2 diabetes, right? So there are multiple things you can get to learn from these guidelines, right? You can learn from these guidelines. Okay, so they have given here most common causes of monogenic diabetes, like MODY. There are genes like HNF, 1A, HNF 4A, HNF 1B, and GCK. And for neonatal diabetes, there are multiple genes which are responsible. So you will come to know in these guidelines. Okay, and then screening for diabetes and GDM, gestational diabetes, as we were discussing yesterday. OGTT, perform a 75-gram OGTT or 50-gram GLT, right? Non-fasting or GCT. So these are the perfect criteria. Suppose I'm talking about GDM. So the perform a 75-gram OGTT with plasma glucose measurement is fasting when the patient is fasting and at 1 and 2 hours and 24 to 48 weeks of gestation in individual, right? So the fasting, if it is up to 92 mg, then normal. Then 1 hour, if it is 180, then normal. If it is 2 hours, then 153, normal. Okay, otherwise no. You can consider them as a GDM patients. Okay. Okay, guys. So you will see all these here. Now the chapter 3, chapter 4, there are multiple chapters. See, this is like what are the diabetes, comorbidities and how to delay them. There are multiple things what you will study here, right? And then comprehensive diabetes care. So see, look at this. This is amazing, amazing. Decision cycle for a person-centered glycemic management in type 2. Assess the key person characteristics. Assess the key person characteristics. What are the key persons, like comorbidities, lifestyle, health, behavior, individuals priorities. Then consider specific factors. Then utilize the shared decision makings. Then agree on the management plan. Measurement plan is like smart, so specific, measurable, achievable, realistic and time limited. That things I will even discuss in our classes, right? Behavioral factors, they have described everything very nicely. Okay. And these are the other comorbidities, infections and all. Okay. And here again the check for infections and HIV and all. And TB, tuberculosis and sepsis are one of the major infections in the diabetic patients. Okay. And if we go to the treatment part, if I'm not wrong, that is on the 130 page number. Okay, so what's that? That is again importance of the 24 hours physical behavior for diabetes. You must read it, you must go through it, guys. I'll share the guidelines in the group. You must go through it, whatever. Everyone has not attended, but all 33, 35 who are in the class, please go through these guidelines. These are the major important thing to understand. Like, see, if you are in the 8 hour sleep, proper sleep, then your glucose will come down. If you are sleeping properly, if you are breaking up for the prolonged, if you are sitting for the prolonged time, then it will go up. Okay, your physical functions and strengthening, they talked about everything, how you should behave in the 24 hours, right? How you should divide your 24 hours for your physical activeness, your health and your health related conditions as well. Okay, so this is the glycemic targets. Okay, here we have discussed all the glycemic targets in our first series, right? In our first series in different patients. Also here there are all the glycemic targets we have discussed. That was our first season of diabetes. This is the series 2. So here we are talking about all medications and the treatment part, right? So this is about home care. You can study about the home care here. And now it comes, yes, 130, right? Obesity, weight management is here. I'll show you one chart, that's all, and then we can end up the class also later. Okay, chart means the algorithm. Okay, and then we will discuss the things in the next class. So see, this is nothing but simplified overview of indications for beta cell replacement therapy in type 1 diabetes. Here is the use of medications in the management of management of diabetes 2, right? So if I can just yes, here, yes, I can. Okay, here. Okay, see, use of the glucose. See, first of all, healthy lifestyle behavior, diabetes, self-management, education, and supporting system. And then based on the glucose achievements, you have to find out what is your thing to take up. Okay, like first you have to take care with the dietary modifications and lifestyle modifications. If it doesn't work, then you have to go for metformin, and if it's not working again, then combination therapy. And then if it is not working again, you have to go for like very high efficacy is semaglutide, and then high efficacy is GLP-1 RA, and then DPP-4, and then there are other things that we are going to discuss further in that. And I think I'll take these two things. So here are the references also. Okay, here are the references also, multiple references you can read about those papers. I'm sorry. Yeah, so here are all the diabetes for the first 30 days, first month. Bigonides, metformin, their dose 850 mg, 1000 mg, sulfonylureas, glyburide, glibenclamide, glyburide, then thiazide, diadions like pioglitazone, then alpha glucosidase inhibitors, then meglitinides, then DPP4, SGLT2, GP1. We are discussing all these in one class because there are multiple drugs, their side effects, everything, right, guys? So I'll share these guidelines with you in the group, and you can just read those and you can just go through these, and then it will be easy for all of you to go along with me in the classes, right? We will discuss the algorithm and then drug classes one by one, okay, from the next class. So that's all for today, guys. If anything, please ask me.